Hello and welcome back to the CRISP TV. I'm your host. My name is Dr. Abad Khan. I'm an interventional cardiologist practicing at St. Joseph Hospital, Ghaziabad. Today is the first day at the CRISP TV conference, and with me is Dr. Anand Rao. He is an established and famous cardiologist working at Lilavati Hospital, Mumbai. So, welcome.
Hello, welcome. Thank you very much for having me over here. I think it's an astounding conference and everything is going on so well. So
Yeah.
it's going well.
Yeah, sir. We just had an insight, and you have talked in length about the SHOCKWAVE India 2 study, which the data you have published. So, why do you feel that the like we have seen that for calcium modification, rotablation did great job, but at the end of the day, it was no difference in the long-term outcomes to the balloon angioplasty. Why do you feel that intravascular lithotripsy is going to change the long-term outcomes which rotablation could not do?
Right. So if you understand, rotablation is a forward cutting device, and rotablation does ablation only of the superficial calcium. Once there is a superficial calcium, Rota does an excellent job. Rota has got its own limitation because it only scrapes the superficial calcium. It does not do anything to medial calcium or a deep calcium. Whereas if you look at the IVL emits the sonic waves which goes very deeper to media and adventitia. So I think to get those kind of deeper cuts and deeper ablation, IVL plays a very important role than rotablation. But having said that, many times you need a combination therapy. For example, IVL is a bulky balloon, so it's very difficult to negotiate this balloon. So if there is a lot of superficial calcium, the IVL balloon will not go. Sometimes even a regular balloon doesn't go. So we need what we call it as first doing a rotablation, remove the superficial calcium, do a proper imaging, understand everything, and if there's a deeper calcium, we have to use an IVL to ablate the deeper calcium so that you prepare the bed well and then your stent implantation becomes better. Second thing is, with rotablator, you don't get a luminal gain, whereas in IVL, you get a luminal gain, which I think is a unique part of IVL. But having said that, I reiterate again that IVL is not an easy device to handle. It has to go, it's a bulky device, it has to go and stay in the lesion. So most of the time, you need something additional before putting an IVL balloon in there.
So, sir has perfectly put that no device is superior to another device. Every device has their own pros and cons. Rotablation will do an excellent job if there is a superficial calcium, and for deeper calcium, maybe nodules, and lithotripsy may work just better than an rotablation. And obviously, the luminal gaze will be far more superior, and hence anticipated outcome, long-term outcome may just be better as compared to a angioplasty or rotablation. So last year we also had a discussion about DCB on CRISP PV. This year, I just want your opinion on the way you see forward at once we have lots of calcium modification devices available now in the future, and what is the role for this the devices, the IVL devices, they have a forward-looking emitters also. Now we are anticipating forward-looking emitters also. Do you feel that the other calcium modification devices, with already Eclipse trial showing no benefit for the orbital atherectomy, and now forward-looking emitter for this lithotripsy is coming, do you feel that other calcium modification devices may just fall behind?
Well, you see, there is a new device, as you said, it's called as Javelin. Javelin is like a microcatheter which has got an IVL placed in the proximal segment. So it starts emitting over there the sonic waves, and that makes a channel, and that goes into the situation, and then subsequent device keep going into the lesion. We don't have much experience, we don't have the data, but it's very promising. Well, once it comes and once it does trials and once it proves your benefit, so I think there's enough scope to anticipate and to see that more and more new devices will be there coming into this, and that sort of helps us to address larger amount of patients and population.
So at the end of the day, it is we are doing all this technology, help in technology, all the momentum gain from the improved technology on the devices. This is to help the patients, and this is what we're looking forward to. Sir, you had a very interesting take on, you already had said earlier also on DK crush troubleshooting also. Do you feel DK crush still holds the standard technique of choice for bifurcation PCIs, where even the senior operators are now, first of all, they like to do mini crush. Now they are moving to the side branch, maybe a drug coated balloon and then main vessel angioplasty. What's your suggestions and thoughts on that, sir?
Well, DK crush has proved its point. If you see data versus mini crush versus provisional, in every point DK crush has proved superiority. There is no question about it. So here's my take, and here's what I think we should follow, that the larger the vessel, I think DK crush should be a go-to sort of bifurcation strategy. But if you are talking about a LED diagonal or a circumflex OM or a PDPLB kind of things, I think mini crush would also do a great job. So for the larger vessels, proximal vessels, I think DK crush is still superior. But having said that, DK crush is modified into various steps now, and there are almost 13 to 15 steps to do in a DK crush, and it's elaborate. You need at least 3-4 balloons, few wires, stents, and plus imaging. So DK crush is not something very easily done. It comes with practice. But having said that, I will not advocate DK crush in every lesion, but definitely in larger vessels and bigger vessels. Advantage of doing a DK crush is your access and scaffolding of the side branch is much better. The scaffolding of the side branch is much better. The luminal gains are much better, and overall, I think even for a reintervention, if there is a problem, DK crush would help us. So I think larger vessels DK crush is a treatment of choice.
Okay, so point well taken. For the largest vessels, sir, Dr. Anand Rao still advocates that DK crush may be the preferred option, despite knowing that the length of the procedure may be longer, the use of more devices may be more, and eventually the cost may be more. But still, for long-term better outcomes, DK crush still remains the gold standard for bifurcation PCI, especially if the large vessels are involved. So, do you feel that currently the technology is outpacing the operators? I see it as most cardiologists are not able to fully learn the previous technology which has come in maybe 3-4 years, and the new one comes along without expertising on the old one. Imaging is definitely one of those fields. We are yet to have we have an array of cardiologists who are not absolutely well trained with IVUS and OCT. Now we have an NIRS which has come in, and the dual modality in a single catheter which has come up. How do you see this technology which is outpacing the operators? Where do you find the correct line and the balance?
So I think, I'll make this point very clear. See, you have to know imaging. There is no question, because we are addressing more and more complex case, and we are taking all the cases which were surgical cases. Now we are doing that. So we are competing with the surgeons, and we have to give them good long-term results. To do that, you have to understand, you have to place your stents well, you have to prepare your bed well, and you have to get a good long-term outcome. How do you do that? You have to do with imaging. So let me start here. Let's not get confused with so many imaging modalities coming into our practice. First and foremost, the funda is you have to know one imaging technology. And if you ask me which imaging technology you have to know, it's IVUS. First and foremost, you have to master yourself into IVUS, because it is it's live. Second is you can use it as many times as possible. Then it is not dependent on blood clearance and all those things. So IVUS is one thing, and now with newer IVUS images machines, 60 megahertz and all those things, and faster pullback and all those things, the imaging quality is very superior. It is extremely good quality. So let's not get worked up about so many imaging technologies coming, but one imaging technology should be there in your lab. And if you ask me which one is that, I think I will keep an IVUS, because renal failure, non-renal failure, proximal, osteal lesions, where OCT has got a little bit of problems, the IVUS would take this thing. Where does NIRS stands in this? NIRS is obviously an IVUS catheter, but it's got additional advantage of showing the lipid pool over there. There's a lipid pool, lipid burden index, what we call it as lipid burden index. That becomes more of academic discussion, but it also helps in the patient. For example, if it's an acute MI and you do a NIRS and you don't find a significant lesion, but you see a lipid-rich plaque over there, so you strategize on the medical therapy. whether this guy needs Ripata, Inclisiran, all those things. So that definitely reduces the lipid burden index, and there are studies to prove that the lipid burden index goes down quite significantly. So let's not get into all these modalities, but I think one imaging technology has to be there in your lab, and if cost effective, if you want to be ease, whatever it is, IVOS. But problem with IVOS is there's a steep learning curve. Not many people will understand and understand those images, whereas OCT has simplified that. So there are advantages on both the sides, advantages and disadvantages on both the sides, but you have to have one imaging modality in your lab to address these cases.
Perfectly placed, and going by the guidelines also, Dr. Anand Rao says that imaging is mandatory. Whether you choose any of the modalities, his preference remains because of so many reasons that IVUS at least should be learned by all of the people and all of the operators in this day and age where there is class 1 recommendation by both ESC and ACC. There is no way any operator anywhere else should be performing angioplasties without performing an imaging, and obviously the newer technology helps you. It will be better if you choose a technology. If it is not, but at least an imaging modality has to be done before and after the procedure ends. So being the course director, how do you feel after such a fantastic response on the first day? And what's in store for CRISP 2026, sir?
So we are happy this conference has evolved. Last time it was just like an experimental thing, and all our minds were there. We were very, very stressed out. The course coordinator, directors, and the whole team, such a lovely team we have. We were all stressed out, and last time it just panned out so well, and we got so much of feedback, and this time we were actually under pressure, because now the bar has to be raised high, because people are coming out with a lot of expectation. That's why the whole thing is the venues changed. We got the second hall over here, which is a noise-free hall. As you see, it's a completely noise-free environment. So this is what we raise the bar right now. And 2026, yes, I don't know, but how to raise this. But I think with all you guys coming into picture, we are very excited. And let me tell you, Chris is going to be a earmarked conference, not only national, it's going to go very soon international.
That is nothing to say further. And Dr. Anand Rao was with me, and we had an incredible insight from him. And hopefully the rest of the remaining days go even better than what it was today. Thank you, and see you on the next podcast.
Thank you very
sir.
much.
Thank you, sir.
Pleasure.
Thank you. Pleasure.
Thank you.